All right, good morning. Happy Monday, week 2. Woo. And I was asking while people were joining in, how was everybody's weekend? Did you have a weekend? Did you do anything? Good morning, Claudia. Besides discussion boards and all that fun stuff. Worked and studied, ate good food. Oh, Blade Runner, wow. There you go. I watched, what did I watch? Enola Holmes. I'd never seen that before. It's pretty cool. Ooh, yep. Eat good, worked a double and did homework. Wow, ouch. Cool. The Padlet seems to be going well. So shot a maternity session. Started a new job and did homework. Ooh. And the Padlet seems to be going well for people. Just a reminder, make sure you add your name someplace in your initial post or the comment. Most people are doing that, but there's a couple here and there that it didn't come through or I didn't see it, and it's hard for me to grade it. But if you already posted and had 2 comments, you should have a grade unless you posted after like 10 or 11 o'clock last night. And I'll catch up today on that. Your Nurse Logic ones are turned in and graded. And the assignments for this week, at least for my class, are the growth and development templates. You may have some of those from last semester. You may have them from growth and development. So that's fine. You can upload those. I think everything comes through now. Amanda and I were on Hangouts last night. She's saying it doesn't open. This doesn't work. So everything should open. The example should open. And the blank one should open. You don't have to do it on the template if you don't want. You can make your own template as long as all that information is included. And please remember to include Kohlberg. So if you already turned it in but forgot Kohlberg, you probably got a note saying, please remember Kohlberg. And the assignment's not due yet, so you can just add that in there, and I will grade it once that is complete. You also have a quiz coming up on opening up on Friday. And that will be over my lecture Friday and my lecture or class Friday and class today. So it will cover spirituality, culture, family dynamics, including abuse, child abuse, and intimate partner violence. And then today it will cover development and yeah, it'll cover development. That's what it'll cover. I'm trying to think in my head. What did I put there? So any questions before we get started? Any housekeeping, parking lots things? Everybody know where they're supposed to go tomorrow?
For those templates, what's the Kohlberg thing you were talking about?
So who's Kohlberg? Anybody remember Kohlberg?
It's part of the psychosocial development, right? Like Erickson.
Right. So Kohlberg was, remember, yeah, Erickson Piaget. Thank you, Francesca. That's just where I was going to go with that, right? So the template asks you Piaget and Erickson for developmental milestones, but it doesn't ask specifically about Kohlberg. And so he has the moral stages. So if you can add that in, for what template of the 4 would you not need to address Kohlberg? Right, infant. At what age can you start maybe addressing Kohlberg? Toddler, right? So 2, 3, somewhere in there, right? Because what is a toddler's, if you will, moral behavior based on? Why do they do things? Or rather not do things.
Parents and stuff and what they've seen other people do.
Right. What are they afraid of in the toddler stage?
I think that they're afraid. They're kind of, they go back and forth between wanting to become their own people and feeling guilty that they want to become their own, I should say person, become their
Correct.
own person, right?
Correct. And yes, and so they're afraid of punishment. They're afraid to do things wrong, as Vanessa was saying, right? So a lot of their behaviors are that they don't want to get in trouble. They're not doing it because it's right or because they've thought out the whole consequence outcome thing. It's they don't want to get punished or have, you know, time out or something like that. Does that make sense? What's the rule on timeouts? Times out, timeouts. How many minutes?
Is it minutes per year age or something?
Right. So if you had a 5-year-old, how many minutes would you put them in timeout?
5.
5. There you go.
You
So
should
we
consider
kinda-
time ins though.
Pardon?
You should consider doing time ins though instead of time outs, because they
Ooh.
can feel abandoned. Time ins is kind of like a, hey, let's reconnect, you know, and so we're both there together and trying to understand kind of what went wrong. Obviously, this is going to be like, it'll depend on the kid and their developmental, you know, level or whatever. But I've been doing them with Willow since she's.
So
smart
is that
enough.
more like I'm intrigued by this idea because I kind of would do this after, like I probably wouldn't even do the minute per age thing, but we would like, okay, now that you've taken a breath or, you know, calm down, let's talk about, you know, once they can understand, right? I think that's probably really, really important. And I'm trying to think what else.
Very important as well, like telling them what they can do is most important as well.
Right, because you want to, instead of, I always remember like being at the pool and the lifeguard being, don't run, right? So it's the first thing you want to do, run, right? But if you say,
Please walk, just please walk. Yeah.
please walk, you know, give it to them in the positive, what you want them. And we as nurses, we model that behavior, right? So like if I'm in a room with parents and they say something that's kind of, I'm not so sure about, or, you know, then I'll speak to the child in the way, you know, to model the correct way to interact or speak with the child. So that's good, right? Let's see, let me go ahead and let's review. Oh, well, it would help if I had the right thing up. One moment, please. So everybody knows where they're supposed to be. The vaccine clinics, things are going well. All that kind of thing. You guys getting a lot of experience? I know Dr. Shepard's working really hard. You guys have the the Taylor Farms education coming up. I think that's tomorrow, right? Is that Roberto?
Yeah, it's tomorrow.
Tomorrow. Amanda, still not clear on the NICU. Remind me whose group you're in?
Dupree.
And what's the question?
So I am going to be at the NICU tomorrow, but it's just me. So I don't know who
Correct.
my point person is or
Mrs. Thorpe. Mrs. Thorpe will be your point person. So what we did with, I'm trying to find the schedule, make sure I'm telling you the truth. Dupree, there we go. So what would probably happen is that you're going to meet with Ms. Dupree like all together as the group, and then she will walk you down probably to the NICU and or to Mrs. Thorpe, who will walk you to the NICU. And there's usually like a little reflection to do. If you can't find one, let me know because I have one for the NICU. And what we're doing is the reason it's in Med Surg for that group is because we are considering that a pediatric experience. Right. And so that's why everybody gets to go to the NICU in that one. And then for Mrs. Davis's group, you're not going to the NICU because you're going to Alsana, which is the adolescent nutrition experience. But my group, as part of your days in OB, you'll go to the NICU. And basically, trying to think, yeah, at Natividad, like that's where Mr. Espinas works, and my friend Kelly works there. But like I know a lot of people that work in the NICU there, and you basically, the nurse only has 1 or 2 babies, generally speaking, so you can follow the nurse between the two babies, and depending on the acuity, then you know, you might be able to change some diapers or reposition or help with feeding or do some education, some things like that. Figure out what all the monitors are for, if they're on oxygen or whatever. So that'll be good. What else?
I had a question about the Maternal Well-Being. We have the seminar that we signed up for and scheduled for that on for actually tomorrow, which means I'm off tomorrow, correct? And then
Correct.
when you register, it says that it's only open for the Friday on the 5th.
Yep.
I'm assuming that we'll get some kind of email or something to register for the 16th. Is that correct? So that way we can attend that one too.
That is a good question. Has anybody that's registered already? My guess is you probably have to register for each one.
There was no spot to do that though. It was just for the, it says that it was just
For the 5th?
Yeah.
Okay, then go make sure you all register for the 5th. And then I will also ask Mrs. Thorpe, let me write that down because she'll have lecture. And do you want me to ask her to maybe start like at 11:15? If you guys are just getting out of that seminar at 11?
Yeah, that'd be great.
Is that, yeah, people? Okay, 11:15 Friday. You'd still go for the full amount of time, but just shift it like 15 minutes at least so you could catch your breath and regroup after that. And I'm still working on uploading the video from December. So I'll post that as well. Good question. What else? Everybody good? Yeah. Okay. So I'm going to go ahead and share my screen. We should be on the little babies. Good morning.
Yes.
Yes, thank you. And so we're going to talk about just kind of review development a little bit and kind of focus on mostly autism, but we'll also talk about Down syndrome a little bit. And so we're going to review the concept of development, which we've already started, by the way, and then talk a little bit about developmental delay, how you notice that, what things you're looking for, and then we have a case study to kind of work on together. So for development, the reading was Giddens, which was chapter 1 development, which is one that I believe you had from 47 and are in 47, but I did add the growth and development PowerPoint from 47, especially for students that weren't here last semester, but remember we talked about development, or if you don't, it's there for you to review. And then, excuse me, we also talked about, again, in 47, we talked about health promotion. So I put the PowerPoint from 47 up as well, because we've covered that already. What we're going to focus on today is tertiary prevention. So does anybody remember, or can you tell me what primary and secondary prevention are?
So primary prevention, Ms. Solinger, that's like immunizations, exercising. Secondary prevention would be like screenings, right?
Mm-hmm. Exactly. And so those are important, and we're going to talk about those as well. But then when we get into developmental delay, then we're going to focus on the tertiary prevention. So you have that. And then you had some articles. Sorry, I didn't realize the links weren't there till later, but the links should be there now. So hopefully you have those interesting. What did you have any specific takeaways from autism spectrum disorder? What takeaways? If you had to summarize the reading, or if you learned something new, or.
Well, I found it interesting how often the screenings are really not followed through by a lot of primary pediatricians. They may know the, I guess I would say, obvious things to look for, but as far as doing the continued screening, I think it seems like a lot of stuff is missed and not followed through because of that.
What other takeaways did people have? I think that is, I mean, yes, I can't agree more with you. And for
One of
some,
the things that I took away was that it's a spectrum, like it's not either you have it or you don't have it. There are different kind of levels of having it and different degrees of having it and stuff like that.
right. And that may be play into what Raul was saying, right? Because there's certain degrees or the spectrum. And I want to be respectful. I'm not trying to pry, but if any of you know or have children with autism spectrum disorder, please, feel free to correct me in anything that I'm, not up to date on. I appreciate that. Because, it's difficult. It's and challenging. So what do we think about, did anybody go to the milestone tracker, the CDC milestone tracker? I think that one's actually kind of cool. I like it. There's actually an app, right? There's an app for everything, right? But you can actually, have the parent upload it on their phone, right? Get the app on the phone and then you see what the developmental milestones are. And I think that helps with expectations, right? Because how many times, well, so-and-so's child is doing this and my child isn't, or my child's way ahead because my child's doing this, right? You start to, compare and contrast. And what do we know? What is growth? If you had to compare and contrast growth and development, how would you do that? What definitions would you give? And I cannot see my chat right now. So if people are putting things in the chat, I apologize. I can't see them. So how would you define growth? Let's start with growth.
I would say that growth is more related to physiological processes like your cells growing and replicating, whereas development is more related to like psychosocial, cognitive development and reaching certain milestones throughout your life.
Right, that's a good definition, Maimai. So growth is considered like height, length, weight, you're physically growing, whereas development is reaching those milestones, being able to, language development, social development, all that, personality development, all those moral development, right? All those theories that we talk about. So that is generally a definition or a question that you will see someplace, either on the NCLEX or a quiz or a test or something. So if not here, it's generally some type of NCLEX question. The other thing that you need to know are developmental milestones, which again, you can get from those apps. You can get them from I'm going to show you this developmental milestones chart, which I think is amazing. You also have in your ATI Care of Children, talks about health promotion. If you want to, I think we went through that in 47, but you're welcome to look through there because there is always some type of question on the NCLEX and generally on a quiz or test that has to do with some kind of growth and development milestone, which is sort of the focus for today, because what if a child isn't meeting the quote unquote normal growth and development milestones? What do we need to do, or how do we educate?
Well, wouldn't you want to do like more assessments? So you would want to ask like their nutrition, and then you would get like the family genetics or background.
Right, you want to ask more questions, right? And it could be that it's perfectly normal, because what's another characteristic of development? It follows in an orderly sequence, but everybody goes at their own pace. Right? You have to crawl before you can walk, but you may crawl at 7 months, they may crawl at 9 months, but you crawl, even if it's only for a day, and then you pull to stand and you start cruising, and then you take that first step. So development follows an orderly pattern, just everybody kind of goes at their own pace. Even twins, in twin studies, they'll find that it doesn't exactly happen, exactly at the same time, even for twins. So going through and looking at, which is why The templates will help you because often it's, you know, when can the child roll from front to back? When will the child sit? When do they crawl? If the child isn't walking by 12 months, you know, what questions are you going to ask? So in other words, if the child isn't walking at 12 months, what would you want to know happened previously to the 12 months, to them being 12 months old?
What it looks like the cognitive and emotional growth actually plays into their development in those areas. So
right, and then also looking at, have they reached those other milestones already? Right, you know, when did they start to grab on and cruise, you know, holding on to the furniture, and did they meet that milestone, and when did they do that? Yes, and looking at the environment, all those types of things play into that. Okay, so let's look at what I put up for you was growth and development. So this is just a sort of quick summary of well, kind of mostly what we just talked about. So those are just the outcomes for the day. It tells you, we're just going through adolescence, so it tells you kind of the age ranges. So neonate is up to 28 days. Adolescence can be broken down into a couple different ages. And then early childhood is the toddler preschool, and middle child is the school age. And so here's your definitions, right? Increase in physical size for growth, acquisition of skills and function for development. The growth happens cephalocaudal. So it starts at the head and progresses to the feet, and it goes from the center of the body out to the extremities when you're looking at growth. Orderly sequence. So we just went through, so this is just basically, I just basically summarized this whole thing for you, which is good. And then the different theorists. Why is it important for nurses to understand the different theories of growth and development?
to whether or not their needs are in certain areas, like trust versus mistrust. You know, if they have issues with that, then it kind of plays into their roles, and it just kind of throughout their different age ranges.
Right, exactly. And so I think it's really good in anticipatory guidance, because if you can, I always use the example of toilet training. I think we did this again. I probably am repeating myself, but for toilet training, what's the average age, you know, for a child to be toilet trained, potty trained?
Whenever the heck they want.
Pretty much. But there's certain signs that we look for, right? And what are some of what are some of those signs that we those signs, cues that they're going to give us that they're ready to even try potty training?
When they let you know that they have to go, or that they already went, even interest in, you know, the adults potty questions.
Yeah, exactly. So there are some people maybe that don't realize that and think, oh, my child has to be potty trained by the time they're 2, or, you know, girls usually learn to train faster than boys. Yes, no, maybe. And so, you know, the girl should be by 2 and the boy should be by 3. Well, my kid wasn't potty trained till 5. I'll just tell you that right now. And his daughter, my granddaughter, she's 5, so 4, I think, maybe, right? She just didn't have the cues, right? And so if the expectation of the parent is that the child will be potty trained by the time they're 2.5, for example, and the child isn't, how's the parent going to feel about that?
They either think there's something wrong with their kid, or they think there's something wrong with the way that they're parenting. If they're, you know.
Right. I'm going with they think there's something wrong with the child.
Yeah.
Right. And so then what happens? Potentially what could happen? The parent's going to get frustrated and angry, probably at the child, because they don't understand growth and development and all those things that we just talked about, and potentially what can happen then.
Abuse or neglect.
Yes, abuse or neglect. That's where I was going. Thank you. So that's why I think the anticipatory guidance, not just toilet training, but in general, right? So parents understand what to expect and what to expect in terms of if my child isn't doing those things, that I need to contact somebody, that we need to get evaluated. We need to follow up. And so I think that's great. So we're focusing on Erikson, Piaget, and Kohlberg for today. This is one of the, I don't know if that's big enough for you guys. I think I can make it bigger. This is one of my favorite little pictures that I have. I found this a while back. It actually shows you Kohlberg, Piaget, and Erikson, their stages and how they line up with each other, right? Because we talk about them fairly separately, but I love this one because it puts it together. So trust, autonomy, like you were saying, Kelly, initiative, industry, and we're going to be going through adolescence, right? So what's the difference between concrete and formal operations? All right, let's think about concrete. What is concrete? Just regular old concrete, asphalt, asphalt and concrete, whatever. What is it? Hard surface, soft surface, pliable.
Hard, set in stone.
Yes, hard and set in stone. So if you take that analogy into a thought process, and you're talking about, 7, 8, 9, 10-year-old, what would concrete thinking be?
Something along the lines of, like, I understand that physically hurting someone else is bad, whereas formal would be like they understand why it's bad. Am I on the right track here?
Kind of, sort of, yes. Yes, so concrete is like you're saying, set in stone. Like I can't imagine possibilities. I can't extrapolate. It is what it is in front of me. Yes, they have imagination, but that's different than being able to think about if I turn this a certain way. Conservation, right? Putting water in 3 different glasses, but they're the same size, or even though I started with this amount, but I put it in 2 different glasses, they can't figure that out. Whereas once you go to formal operations, then you can see that they can look at it from different angles and see how that works. I have, I think in the developmental PowerPoint, there's videos, or actually no, this one, right? So there's videos that you can click on when you run the PowerPoint that will show you different examples of those.
You're saying formal, they're basically they grow into the ability to see other viewpoints and to understand other views of things, right?
Yes. Yeah, on the one video we have a picture. It's like a diorama of like a mountain, and there's some animals and trees. And they ask the boy from the he looks at it from this side, and then they have him look at it from the other side, and then he goes back to the first side, and they say, okay, what do you see? And he says what he sees, and then they ask him, well, what did you see when you were on the other side? And he can't tell them. He just continues to tell them what he sees from his point of view. He can't extrapolate to what it was he saw on the other side. So yes, being able to look at different points of view. And oftentimes, again, there are questions on the developmental stages and what they mean. You guys can all look at that. I just wanted to remind you, and then Kohlberg as well. And that breaks it into the pre-conventional, post-conventional, all of that. So that was kind of a quick review there. And then the developmental milestones charts. This I thought was, I believe I took this from American Academy of Pediatrics. I really like these because this particular one, which is why I gave it to you, because it talks about, it divides it up: gross motor, fine motor, you know, self-help, problem solving, excuse me, receptive and expressive. What's receptive language? Anybody?
Is it like the ability to understand, like being able to understand and know what you're like, what they're saying?
Right, to receive it, to receive the language, right? And so for example, when you're talking about an infant here, they're going to look at the speaker, or they hear it, and so they start turning, right? They start looking at, they hear mom's voice, right? And they start looking. That's receptive. We talk about that a lot in aphasia when you have stroke patients, being able to receive language, but they can't speak it. They don't have expressive language. So that's expressive language, is being able to take what you received and then give some proper response back to it. So I thought this was a good summary for you. I know it's a lot. I don't expect you to know all of them. If there's a particular one, I can probably let you know that. But when studying for like the NCLEX, I think this is a really good summary, or at least to understand how development moves in all those different areas. And it goes through 6 years old, and then has a couple more paragraphs, and there's something, here it is. And then the neonatal reflexes, right? Because you need to know those in your newborn assessment, right? And so I thought this was a nice summary of the reflexes: the rooting, sucking, the startle, Palmer plantar, the tonic neck, Babinski. Those are the main ones to know. So I thought that's why I gave you that, because I thought it was just a nice succinct summary there. And we talked about that. And then if you need a review, there's Erickson, Piaget, Kohlberg. They'll take you to pages that talk about those particular theorists. And then also there's some information on toddler, preschooler, and school age nutrition for that, if you need that for your templates. And then let's see. And I think we're going to start to move in. Okay, so what I would like to do, let me stop sharing. Oh, look, there's the chat. There we go. I would love to do a little think, pair, share, and break you up into breakout rooms with like two or three people, and come up with 1 or 2 questions that would relate to growth and development. So in other words, you're going to write your own quiz question. Like, so what would you expect to be asked? Multiple choice question is fine. You could do fill in the blank if you'd like. Not really short answer. But I want to give you like 5 minutes to think with your partner about expectations of growth and development questions. Like, does that make sense? Right? To get you thinking about, well, what could possibly I be asked on a quiz, or what do I need to really know? Okay, so let's do, and we are back. How was that little exercise? I popped into about maybe half of the rooms. You guys seem to be getting it. And take a couple examples. You could either put them in the chat, like I think David has one in the chat, or you can, offer it to us. Kind of your thoughts on your question.
We talked about just knowing like what foods would be appropriate for whatever age range. Foods to stay away from, like high risk allergy foods like peanut butter, strawberries, and then choking hazard foods like hot dog or celery. And then we also talked about just knowing the difference of the developmental stages, as well as like the fine and gross motor skills, like what age group would be most able to do whatever activity like riding a tricycle and that sort of thing.
And so how did you guys phrase your questions?
The first one, sorry.
Or just, yeah, one, that's okay.
The first one that I have says, what food would be most appropriate for a 2-year-old? Would it be grapes, celery with peanut butter, hot dog, or cooked broccoli? And then the other one was, which gross motor skill would you expect a 4-year-old to perform? Throws a ball overhead, walks up and down the stairs by placing both feet on each step, draws a circle, or rides a tricycle.
Okay, I like that one. What do you guys think is the answer for the 4-year-old?
Are you asking me?
Well, I'm asking the group,
I
right?
would say rides a bicycle.
I think it was tricycle.
Tricycle. Oh, tricycle.
So there was throws the ball overhead, walks up and down the stairs by placing both feet on each step, draws circles, or rides a tricycle.
I would guess draw circles.
I would say A and C.
I would say throw the ball overhead.
So throwing the ball overhead would be the correct one. And drawing circles is actually a fine motor skill, not a gross motor skill.
Ooh.
And then the other ones are for different ages. And then the first answer for the food would be cooked broccoli, because you would want them to have soft stuff, not things that are choking hazard or have allergens in it.
Mm-hmm. Yep. So that's great. That brings up the point, what's the question asking? Gross, fine motor? Yeah, perfect. Nice job. Let's see. David has one. Which of the following is classified as a social emotional developmental disorder? Cerebral palsy, autism spectrum disorder, attention deficit, traumatic brain injury. Any guesses? These are good. Look at that. Let's see. Emily, you're assessing communication strategies of a 2-year-old child. You ask the child where the pain is. Which child shows the highest level of developmental achievement? Child says tummy. Child points to their stomach. Oops. Child looks away from you and doesn't say anything. Child says my tummy hurts a lot. Ask child where the pain is. Which child? Okay. What do people think?
Wouldn't it be D? Because he's stating basically that it hurts not just a little bit, but a lot. So he's rating his.
How old is the child? They're 2. What would you expect the 2-year-old to say? I mean, I'm just guessing, Emily. This is your question, but.
So based on the ATI care of children, it says that 2-year-olds have between 50 and 300 words by the time they turn 2, which means that depending on what age of 2 this child is, he would either be using multi-word sentences by combining 2 to 3 words, or if he's maybe a more advanced, he would be combining several words to create simple sentences using grammatical rules.
Because the only thing that throws me is that's it's 5 words. And I wouldn't necessarily expect that from a 2-year-old. However, I didn't like B or C. Excuse me, B or C. I probably think they'd say tummy hurts, something like that. But D would be, I could see why it would be D. I just wouldn't expect a 2-year-old to be able to say 5 words, depending on the 2-year-old. But that would, if they were able to do that, that would be great.
Yeah, so that's hard. So when we're having ATI questions or kind of questions you guys are making, given that people know lots of different ranges of 2-year-olds and stuff like that, are we expected to kind of pick the one that's just the 2 to 3 word one when they say 2-year-old?
That's what I would do. I don't think I would give you a 5. I think there's actually an ATI question and it's how many words in a sentence would a 5-year-old say, and it's a 5-word, it's a 5-word sentence. So yeah, I mean, it's just sort of average basic range. These are really good. You guys should write these down. Not that I might use any, but I might use one on, not the quiz, but maybe on the exam. Developmental milestones. Maybe, I don't know. Some. Nice try, Fredo. Somebody who has strong imagination and intuition, but complex abstract thought may still be difficult. Oh, but complex abstract thought may still be difficult is most likely in which of the following stages? C? Concrete? Maybe.
The answer for that one was B.
Really?
Yeah, that one just came straight off. It came straight off of that, off of the PowerPoint that you posted. One of the things lists like, one of the slides lists, dang it, descriptions of each.
Oh, right.
And one of the descriptions read that stuff on there.
Oh, because imagination, my bad. It's imagination. That's the pre-operational. See, I misread the question. I'm just going to stop with the questions now. No, it's how you read the question, right? Because I didn't even look at that. Oh, I know the answer to this one from Nick. Strict or authoritative parenting is an example of what type of risk?
Should we give the multiple choice?
Family.
So it was.
Oh, go ahead, Raul. Yeah.
Yeah, I'll give it to you. It was A, family risk, B, situational, C, toxic stress, or D, social determination of health. Determinants of health, excuse me.
Toxic stress. No.
Yep, that's correct. Oh, when it says a child should know 2,200 words or 8,000 words, how on earth are they measuring that? Yeah, that's a good question. JJ, I don't know if they sit there with a little counter. I have, I have no idea. That always amazed me. Like, how do you know that? Yeah, no extra credit in nursing school, sorry. Although I did, it's too hard to grade in Canvas. That's the problem. Oh, all right. So hopefully then this was helpful in trying to think of what questions could be asked and sort of how to read the question or know what the keyword to look for is, because I have obviously missed several of the keywords there. Which of the following is a yang food? Oh, you guys. Okay, so let's move on. Yeah, he is. Okay, so we're going to start to kind of move into screening and the prevention and then into delay. So this little drawing here, right? Screening and identification. You guys see that, the multicolored? I see no faces, so somebody's gonna have to say yes. Newborn care, yes, yeah. Thank you. Thank you. So when you're looking at screening, right? Screening would be secondary prevention, and identifying what we're gonna call neurodevelopmental, developmental disorders and behavioral emotional problems. If you can start early with the screening or being able to identify risk factors, then you can hopefully get the child some help, some therapy, some follow-up, some treatment, some whatever. So when you look, which you're going to be doing this semester at newborn care, some of the things, the screenings that we do is we do metabolic disorders, right? How do we test for the metabolic disorders? What is that? We used to call it the PKU, It's a heel stick lab draw. We try not to draw blood in the AC or in the arm. We usually do heel sticks on babies. So hopefully you'll get to see that. We do that to check the glucose as well. And the metabolic screening is they have the card that has the circles on it, and you have to drop the blood into the circles, depending on where you work. Either lab does it or the nurse does it. And that can pull up different metabolic disorders that could have an effect on development. We also do newborn hearing screening. I was the director of newborn hearing screening program at CHOMP when I was in the NICU there. And we would find each year maybe one, although we screened many and many went for second and third hearing screens, we would have at least one, if not two, infants that actually had a true hearing loss that we were able to start early intervention with them. So that was always good. And then we also do the congenital heart disease screening. That doesn't necessarily have to do with the behavioral and emotional problems, but if you can't hear, why is that an issue?
And it plays into speech and that sort of thing as well.
Right, exactly. Language development. Good. Yeah, put the little headphone things on. Yep, exactly. And then once they've had, once they go home and then they go on their pediatrician visits, right? So there's usually one that's a couple days after birth, check on the weight, how things are going. And then 2 months, 4 months, 6 months, that type of thing. And so what we do at those screenings up even through adolescence is when they come in, we check their vision and we do check their hearing again. We ask questions about any behavior or emotions. You can do the MChat. That's one of the ones that we're going to talk about. Any language disorders or, disabilities with reading problems like that. And so those, when you go, it's called the CHDP. If you go to Clínica de Salud, you'll hear them do, it's a CHDP physical, and they do the vision and hearing. I don't know if, I'm pretty sure some of you were able to see that when you were at Clínica last semester. Yes, no, maybe?
Yes.
Yes. Thank you, Vanessa. I can only see Shannon and some picture of Hugo in a white coat. Yes, you did the hearing test with the vitals. Yes. So that was the physical. And that's when hopefully they're asking, the MA would ask those screening questions, right? What are they eating? How are they eating? They do a little finger stick and check for the hemoglobin or lead if it's a certain if they're a certain age according to their protocol. Yep. And then if we keep moving on down, I love this. I found this. I'm like, oh, I love this. So this is the types of prevention. This tells you primary, secondary, and tertiary. So as you guys were giving the examples earlier, primary is wellness care, right? It's universal. You can do it in a lot of different places. It's wellness. You'll hear me talk about anticipatory guidance forever in pediatrics and women's health. All those kind of things, continuity, context, all those things are important. You don't, addressed in training programs, you don't need a whole lot of training. And then huge return on investment, right? Like you guys are going to Taylor Farms, right? And Roberto, what are you guys teaching them?
Going to be giving them some information regarding the COVID vaccine.
Because what are they're finding that a lot of the employees aren't wanting to get the vaccine?
I believe so, yeah.
And so we're going to go, so that would be a huge return on investment. You have a couple students going to, a fairly large or small audience and getting that information, disseminating the information, which is great. And when you're talking to families of children, Bright Futures, we had that last semester. We're going to continue to use Bright Futures as a resource for that, right? So that's wellness care, that's health promotion. That was the focus of last semester. Now we're kind of moving on to this acute or sick care, which is secondary. And so it's a selective or targeted population. So for example, what do we say? Mammograms, right? Mammograms are a screening. And so there's a specific population for whom we want to do a mammogram. And so it's either to diagnose or treat a disease in the early stages, right? Before it gets to be chronic or cause something, you know, gets out of control. And so it's early identification. Again, you can do it in a lot of different settings. The continuity and context are somewhat important, but it's kind of like you go to the mammogram center, right? And then the information gets sent to the physician. So you're going to actually be following up with the physician. And generally it's extensive training for whatever it is that you're, like a mammogram, you know, they have to go through special training to be an ultrasonographer. And then, you know, the return on investment is variable, lots of incentives. So how many people work for a company or a hospital where if you keep your blood sugar or improve your blood sugar, you get a rebate or something on your health insurance? Or if you can show, or if you quit smoking, there's an incentive. Or if you know, walk so many miles or whatever per day. Anybody? Yeah, Hartnell does it as well. We have a wellness. Chomp does it. Hartnell does it. Yep, exactly. And at Chomp, you can bring your family, like your family member can get the screening as well. Know your numbers. Yep. Nice. So there's a lot of places that do that. And then this semester we are focusing on some acute. It's supposed to be sort of stable chronic. And so one of the things, for example, that you're going to see for tertiary prevention is more chronic care. So these are people that have already been diagnosed. And so what you're trying to do is reduce the negative impact of the disease by restoring as much function as you can. So if you think about, for example, a child with autism or with autism spectrum disorder, they've been diagnosed with that, right? And so now we are going to do certain activities, certain follow-ups to reduce the negative impact as much as possible for the family and the child, right? And to decrease complications, stress, that kind of thing. So you're trying to, again, different settings. This is where the continuity of care and the context are extremely important again, right? You need that continuity so people know your patient, right? Does that make sense? Or do you have something, Hugo? No, just clearing your throat there. Okay. So does that make sense? That's why we're kind of looking at the chronic care piece for today. Right? Because we didn't really look at that, but you're going to see, especially like for those of you going to Coastal Kids. So once you come back, I don't think I'm back till week 7 for lecture, but you know, it would be great if you share, you might have children with cerebral palsy or traumatic brain injury or some different things. And so that's chronic care. And so what are the nurses doing or the family doing to reduce the negative impact? I think that would be great for you guys to look at. Any questions on, I'm sorry, as I go back and forth, any questions on types of prevention? People good on that? Hugo, nod your head, yes. Okay, thank you. I can only see Shannon and Hugo, so. Okay, so if we know what to expect and it doesn't happen, then we need to know what to do to follow up. And so this PowerPoint is going to, again, I'm going to kind of, hopefully it'll load there. Somewhat, not speed through it, but sort of speed through it. There are slides in here also about lead poisoning. So lead poisoning isn't a topic, but the slides are there if you'd like to look at them. But I'm probably, if they're here, I'm probably just gonna run right through them. So common best practice in the provision of services to children with special needs is A, care is now being focused on child's chronological age. Children with special needs are being integrated into regular classrooms. children with special needs no longer have to be cared for by their families. Or D, children with special needs are being separated into residential treatment facilities. You can put your answer in the chat. Common best practice in the provision of services to children with special needs. C and B's, an A. Oh, look. I didn't know you could do that. That's awesome. You guys see Amanda's hearts? Yeah. And Aaron, there you go. Oh, gold star. Thank you, Hugo.
Mrs. Diamond taught us that the other day.
Cool. I love it. Except now I don't know how to erase it. Hold on. I gotta.
Oh no, sorry.
No, don't be sorry. I just tried. I know there's a way to do it. And
so if you go to view options at the top, and then you go to, I think it says annotations.
Oh, yeah. Hold on.
It brings up a little bar.
There we go.
When it brings up the bar, you click clear and then click clear all.
Oh, clear. There we go. Clear all drawings. I knew it was there somewhere. Thank you. Alfredo, stop.
But if Alfredo keeps doing it, it doesn't work. So.
Yeah, there we go. Okay, it's all good. I knew it was somewhere. Okay. There we go. I moved mine to the bottom. Nice. Okay, so development, this is in get-ins, right? Delayed. You can also have advanced development. We don't really talk about it, but there's a lot of talented and gifted programs, right? People that are sort of ahead of where they're where you would expect them to be developmentally. So a lot of different causes, things that go into different growth and differentiation, a lot of different categories that we're looking at. And then when we talk about delay, we're looking at social interaction, language, and self-care abilities. So these things are lacking or are limited. Different causes, there are genetic causes. There's problems that can happen in the neonatal phase, during birth, during pregnancy, different childhood conditions or diseases that can affect the child, different environmental problems. And a lot of times you just don't know. And I think those are the hardest ones for the parents, when you can't give them an answer as to why, because that's as a parent, that's what you want it. Why? What did I do wrong? Or what happened? And there isn't always an answer. So there are different, this was supposed to be, I think if you play the PowerPoint, this ends up being a movie, but there's different screenings. You'll hear the DDST, the Denver Developmental Screening Test. That's a pretty common one. It's a little more passé, but they still do it. The ASQ website has a lot of developmental milestones. This is one specifically for early language. The MCHAT is to look for autism spectrum disorder. And then when you talk about cognition, right? So we're pulling in that concept of cognition as well. So is there an impairment, right? What different kind can you have? And we're kind of looking at intellectual disability, because remember, cognition is over the lifespan, right? But we're focusing more on newborns and children. Family-centered care, always important. So when you're looking at the child, you also have to look at the family, what family resources, right? The family history. What does it mean by families grieving? What are they grieving?
The thought and plans surrounding, having a quote unquote normal child.
Mm-hmm. Exactly. Loss of a family member, what they thought or expected. Yes. We often will refer to it as loss of the perfect child. And so to be supportive, referral to community agencies, and have the parents able to do what they need to do for the child when they get home. So there are different, McKinney's an old book, sorry. But there's different types, Asperger's, Rett's, A lot of times we just don't know. Autism is not directly linked to the MMR vaccine or thimerosal. That was, I hope people know that now. The study was false. And usually generally diagnosed by age 2 or 3. Although I believe the statistics, more children are being diagnosed, more common in boys than girls. And what you'll often see, you can see symptoms as early as 1 year of age, mostly noticeable, like we said, between the 2 and 3. You'll see clusters of problems when you're talking about autism, especially with the language and the social development. Of course, it could just be personality, which is why you do the MChat and why you follow up and continue to watch things. Asperger's is another example of what they call so-called higher functioning autism on the spectrum. So things that you would be looking for are telling parents, failure to make eye contact is a big one. Unable to respond to social and emotional cues, right? They don't want to be hugged or held. Lack of interest in other children. Difficult to engage in pretend play. And they tend to line up their toys a specific way or put things in a certain order. That makes sense to them. Ritualistic behaviors. Sometimes you'll see the flapping or twirling in circles, sometimes head banging and biting. So that's a safety issue. Oh yeah, there you go. Fear of dogs, never smiling. But to keep in mind that just because the child is flapping doesn't mean he has autism, right? Because some children have those behaviors, but it doesn't mean that they have autism. And then they can sort of become overstimulated by what we would consider to be normal stimuli. So the screening that you do, hopefully that takes me where I want to go. Oh, yay! Is the MChat? Ah, yes. So this is they call it the modified checklist for autism in toddlers. Because remember, we're screening in that 2 to 3 year old age. And so let me get to the questions, and it will tell you based on the score if they're low, medium, or high risk, and what you need to do. They need to follow up. And so you ask the parents, right? If you point at something, does the child look at it? Have you ever wondered if your child might be deaf? Does your child like climbing on things? So does a typical toddler like climbing on things, right? Like you have to this sort of gives you a snapshot picture. So that's why follow-up is important. Sensitive to light and noise, yes. Yes, Vanessa, some kids with ADHD can have similarities but not have autism. A lot of times the symptoms overlap, right? So as a nurse, it's not our job to diagnose, right? But it's our job to, if we see a delay, to follow up, or if the delay is then identified, then to be able to provide resources and education and follow up for that child. And routine is very important. Routine, safety, we just talked about that, redirecting, education, lots of referrals, physical therapy, speech language pathology, support groups. Like, how do you do a support group now? Yeah, John, that's a great question. Oh, cochlear implants, Emily, that's cool. Right, Zoom. I mean, and I don't know, how warm and fuzzy is Zoom, right, for a support group? It's hard to give a hug or to hand somebody a Kleenex or, have that same intimate feeling. And John's got a great question. Maybe we're going to see more meet the criteria because of the pandemic and being social and isolated. Things to think about. So Down syndrome, trisomy 21, mothers usually, but not always, over 35 years old. There's your incidence. I'd have to go back and look at the statistics. These might be from a couple years ago, but the incidence increases as the mother increases in age. I would say it's probably the first for a primate for their first baby, but it could be subsequent pregnancies as well. And so the prenatal screening that they do, and you will hear about this from Mrs. Thorpe, who's going to go over that. You can do chorionic villi sampling. They take a sample from inside the uterus. There goes Alfredo again. Amniocentesis. Now, I never did an amniocentesis. To me, it was too risky, right? And so that you have to educate again. Do you want them or not? You know, does the parent want or not want an amniocentesis? The nuchal fold thickness, that's what this is a picture of. You can see here on the neck, this would be considered normal. And then this here would be an increased neck fold thickness there. And then there's also some different blood tests that they can do. But waiting for those results to come back can just be like terrifying. The weight, right? The weight is ridiculous. This tells you different ways that the chromosomes get translocated, or there's mosaicism. There's a lot of different types. And then, so if not diagnosed prenatally, oftentimes there are specific characteristics of the infant that that you will see at birth. So, not to be rude, but in our profession, sometimes we say the kid is an FLK, funny looking kid, but that doesn't mean they have Down syndrome. They literally could look like mom or dad, right? But like, you'll see the face, and like, you really have to look at the eyes. You have to look for the simian crease, or you have to look for some of those other characteristics, because you're like, this kid just doesn't look right. And maybe it's another chromosomal abnormality. But there are specific characteristics that generally you see. And this is a picture of those with the epicanthal folds. Where have you heard the term epicanthal folds?
The newborn assessment?
The newborn assessment, right? So a lot of those questions on your newborn assessment have to do with ruling out Down's syndrome, right? So that's where that comes from. So amniocentesis only recommended if they see abnormalities in the measurements of the ultrasound. Potentially, sometimes they'll just, right, even without abnormalities seen, right? Because you can do chromosomal analysis. I had my third pregnancy, I was going to turn 35. So I was 34, and they wanted me to get an amniocentesis because of my maternal age. I'm like, yeah, no, just not going to happen. You know, what happens, happens. But that's a choice, right? To me, it was too risky. Protruding tongue, flat nose, high arch, narrow palate. What difficulty will a baby that has protruding tongue, flat nose, arch, narrow palate, what potential problem do you see?
Eating.
Yep. Right, breastfeeding, nursing, eating, breathing, right? Exactly. And so that's why you have to, and they're tend to be very floppy. So you really have to support the neck and the child. So more definitions of the manifestations, feeding problems, like you said. Many times there are congenital heart defects. So this is sort of a lifelong process and multiple surgeries potentially. Decreased GI movement, difficulty breathing, sometimes hearing and vision problems. Very lovable, easygoing most of the time. What type of client problem? So add this in the chat. Give me a client problem for Down syndrome. Doesn't have to be related to or anything, but like what, based on what the slides we just went through, what are some client problems that you could potentially write about or have nursing interventions for? High risk for abuse, respiratory, GI, so gas exchange, nutrition, safety. Yep, nutrition. Communications, yeah, that's true, Nozomi. So development, alteration in development, not meeting their milestones. Exactly. Milestones will most likely not be met. Exactly. And I would suggest to the students that are coming in, your copy of your Giddens concepts book, the front cover has not the front cover, like the first page has a list of all of the concepts. So that's where the students are pulling some of these from. So what about perfusion? With congenital heart or, perfusion. With children, you can also look at the parents. What type of client problem? Mobility, yes. What type of problem could the parent have? Grief. Stress and coping. Yeah, stress and yay, Kenya. There we go. Stress and Vanessa. Stress and coping. Very good. All right. And so emotional support and safety, right? You said safety, assessing the current level, talking to the parents, make sure there's supervision. And then if you see them in community settings when they're coming for outpatient visits and things, make sure like IEPs, right? Individualized education plans, those types of things are really important in school. So there's a picture on the swim team there. Hopefully there's some respite care, genetic counseling, right? There are a couple things. So there's something called Fragile X. Again, this is not on the outcomes for today, but it sort of falls in that same category and could be confused with autism. So there's a defect on the X chromosome, and this is sort of similar to autism spectrum disorders. And we actually had, I think it was last year, the year before, we had a child with Fragile X, and another one that you might see is Rett syndrome. And we had a client that had Rett syndrome as well. So these are types of developmental disorders. And the cause isn't really known. It is characterized as an autism spectrum disorder. And then the fetal alcohol spectrum disorder, fetal alcohol syndrome, when the infant is exposed to alcohol in utero. And so you have characteristic looks of the child. So they call it the philtrum is smooth, and the thin upper lip, and the palpable fissure is very short there. We can see that's flat and the thin lip. Alrighty. If you are interested, there are, at the CDC, there's Real Stories Living with Down Syndrome. You can actually read about children, adolescents that have been living with Down syndrome and how they've gone through their life with those. So, excuse me. This is an article that's helpful for the case studies. As usual, we're not probably going to get to all of the case study, so let's do it together. And here's some resources I had. We kind of talked about the child abuse last week, so I put those there, and culture influencing children's development. Oh, Peanut Butter Falcon, I saw that. Where did I see that? Is that on Netflix or Prime? I can't remember, but I saw that. Is it Prime? Thank you, Francesca, because I went by it and I'm like, oh, that looks like it might be good. So let me open up part one. So the case study was kind of more developed for being able to diagnose, but I think it's really good looking at the behaviors. And so one of the things, if we look through this, so we're talking about Billy, he's 3.5, and you are seeing him for the first time. So full term, normal pregnancy, delivery, you're gonna hear that now this semester a lot. They're gonna say, how many weeks? Was there anything unusual about the birth? Were there any complications, C-section, vaginal? any meconium, that kind of thing. The newborn screen, right? That was on that algorithm, and the hearing tests were normal. 18 months, he came in, had tubes, ear tubes placed, a bilateral laryngotomy, that means ear tubes placed, because he had repeated bouts of otitis media, so that's an ear infection. The tubes go in to help drain the fluid. And so the mother was concerned because he wasn't speaking any words. So the doctor says, let's wait and see. Oftentimes, because you think perhaps with the chronic otitis that they couldn't hear very well. So now that you have the ear tubes in, you hope that they will be able to hear better. But I don't know, what do you think about that? They did schedule a follow-up for when he was 2.
It kind of makes sense because if he can't hear, then he would have a hard time learning new words to be able to talk back to his parents.
Right. I mean, it's sort of, right, I understand it, but when I continue pursuing, right, you know, maybe it's, I'd have to look at the actual child. The follow-up appointment was scheduled for when he turned 2, and at his 2-year well child check, because of the developmental delay, they did refer him to early intervention, which is good. And so early intervention usually is some type of speech therapy, can be physical therapy, occupational therapy. It can be in-house, it can be at a center, and it's targeted, it's usually one-on-one. And so 3 months ago, Billy began attending a special preschool, and he gets his speech, physical, and occupational therapies. It's the 3rd preschool Billy's attended, and he was asked to leave previous schools because of behavior problems. And the mother reports the preschool teacher said, take him to the pediatrician about the behavior. What do you think about that? Teachers say he's extremely hyperactive, doesn't follow directions, and ignores children in the class.
Not a very good teacher.
And she's a special ed, right? I'm thinking she's a special ed, or he or she is a special ed teacher, right? Because he's in a specialized preschool. So I think that's, but what do you think about the behavior? What's concerning? Anything as a red flag?
Just the not listening and, you know, having that behavioral issue. It's definitely concerning, but it could be a wide variety of things. He could be seeking out attention at that age. I mean, there's so many different factors, but you have to kind of do your, you know, referrals and recommendations, you know, across the board type thing.
Mm-hmm. Yeah, ignoring the other kids, not interacting. I think that's kind of concerning. And 3 different schools. I know that story. I lived that one. He's been in good health, so that's good. But the milestones are delayed, particularly language. So that's a red flag. No history of developmental regression. So what would developmental regression be?
That would be like when a child no longer wets the bed, but then maybe if there's some sort of stress, they go back to those original behaviors. So
regression would be something like that. Oftentimes when children are in the hospital, exactly, they've been potty trained, but now it's stressful and they regress. The developmental regression is more of they've met a milestone and then they lose it. So in other words, the words they made, that maybe they were talking or saying 2 or 3 word sentences, and then all of a sudden now it's 1 word or they're not talking. That's what they mean in this context. But he's been doing better since he's been getting the early intervention services, uses single words. He's 3.5 and he's using single words like juice and cookie, handful, but he calms down when you turn on his cartoon, sweet and loving, so that's good. Prolonged tantrums. So when do you expect tantrums to happen? What age?
Like 1 and 2.
2-ish, yeah, two.
Terrible
terrible 2s, but the 3s are worse. Just saying, just know that the 3s are worse than the terrible 2s. just from my experience, my personal. Some kids do start them very early. What is I still have tantrums. Thank you, JJ. What is a tantrum a reaction to? Why do you throw a tantrum?
The inability to process emotions, something simple like not getting what you want and not understanding why.
Mm-hmm. And they can't express themselves. So that's why routine is very important. I think we'll get through this one and then we'll be done. You guys can look at the other ones. I just want you guys to be aware of, like, looking at a history or taking a history. What are you looking for? What information, right, are you looking at to identify that there's a problem? He frequently bangs his head and bites his hand, which frightens mom. Concerned that he doesn't like to play with similar age cousins, but she thought it's because he was an only child and didn't like to share. She's been waiting eagerly the first day of preschool so he could spend more time around other children, but it doesn't sound like that's happening, even though he's with other children, right? Sister's 7-year-old son is in special ed, but not sure why, and the sister doesn't talk about it. And she's frustrated, right? The mom's frustrated and wants the best for Billy. So I think you guys talked about the important information. Is what other things would you want to know? I think that's always the question. Like, you have this information, what else do you want to know? What should they have done at the 18-month exam, maybe? Family history. Yeah, maybe do an assessment of the child away from the mom. Words they know. Right, a little more in-depth physical, emotional assessment. What should they have done maybe at the 18-month screening, when the doctor said, let's wait and see? I don't know, brain scan, maybe not. Hearing screen, I think is appropriate. Maybe a brain scan, but I think hearing screen before a brain scan. What other screening that we just took a look at in the PowerPoint? Yep, the MCHAT, the autism, right? How difficult would it be to do that screening? You're asking the parents the questions, right? Maybe that would have led to earlier. What if you could have started early intervention 6 months earlier because of this, because the screening showed that, right? That was a possibility, right? More and more early intervention. Let me just show you, you guys are right on track there. What are you thinking? Are you thinking autism, something on the spectrum? And now part 2, he's, he plays, they're in the office, he says it's a ball, which is good. You toss him the ball. He makes some brief eye contact and kicking and chasing the ball. You're trying to interact with him, but he's really not interacting with you. He's doing all these other things. He doesn't answer to his name. Mother begins to undress him and starts to scream and jump up and down and flapping his hands. She says he tends to have difficulty transitioning. He's 75th percentile for weight and height. Head circumference is 98th percentile. He does have prominent ears and a wide nasal bridge and mildly hyperextendable, right? So you like almost double jointed kind of thing. Okay, maybe. Everything's else. So is anything changed in your opinion? Anything else you would recommend? I really like this one, number 4, strengths of the child and the family. We did that last semester in 47, where you were looking at what, right? What is the, what strengths do they have? Which I think is good, trying to find the positives. I don't know, is it necessarily changes my opinion maybe? I don't know about the wide nasal bridge, prominent ears. I don't know. All right. because it's going to end up being something in the PowerPoint that we just went through. Oh, I didn't want part 3, sorry. Because that doesn't, well, if you look at part 3, it shows you sort of the algorithm that the American Academy of Pediatrics uses to diagnose autism spectrum disorders. And clearly that didn't quite happen in this case. And so 6 months later, now he's in the system, he's being evaluated, they're doing all these things. His hearing test was normal, yay. Developmental, he saw pediatricians, psychologists, all kinds of people. And so based on the physical and neurological exam, he meets the DSM, Diagnostic Statistic Manual number 5, for autism spectrum disorder diagnosis. So I would encourage you to go look up the DSM-5 and see what that particular diagnosis is. And he does have the deficits. They also drew blood to check for Fragile X, but the results are still pending. And so he's coming up to the 15 to 18 month level, like he's making progress, which is great. So this just asks you to kind of look at what the etiology is and that type of thing. So it actually turns out that Billy has Fragile X, which is a autism spectrum disorder. And so I think sometimes they're gonna do new appointment with the geneticist and so why would you do possible enrollment in clinical trials? What does that sentence mean to you? Possible clinical trials.
Maybe it's more rare.
Maybe.
Well, they could look at new ways of treating the Fragile X syndrome. Just because it's a trial doesn't mean it's going to be successful, but it could possibly help out a little bit more.
Mm-hmm.
So
go ahead.
It makes me think that there isn't a well-established treatment plan in place.
So clinical trials could potentially be experimental treatments for Fragile X. So sometimes those are available. That kind of put me off though when I saw it. I'm like, why would we need to do this? That's a good thought, JJ. There might not be. Is it not that common then to get more information, more studies, learning more about it? Yeah, for sure. And I think being able to put a name to it, and how do you think mom's going to feel about that?
She'll be, it's mixed emotion for her. She'll be a little relieved because she's going to find out, okay, what's actually wrong, but then a little stressed out because, okay, now we got to deal with this. Now, how do we treat this? Now, where do we go from here?
Right. Is that Abram? Is that you?
Yeah, that's me.
Okay. I can't see you. It sounds like you. So yeah, that's exactly right. I think the diagnosis is often good, but then you've got to deal with it. As a nurse, would the diagnosis change necessarily anything that we had done up until the point that we knew what the diagnosis was? Right, because we're assessing, we're providing resources, right? Those types of things. So, maybe here and there, maybe change, but probably not, right? Keep doing, advocate. Maybe we would have advocated more at the 18-month visit. That'd be about the one thing that I thought of, but. All righty, well, we are done for Monday.